Hello everyone. In this video of Macleod series, I am going to discuss about the basics of heart sounds. All the informations that I am using here are taken from Macleod's textbook of clinical examination. So, without further delay, let me discuss about the first heart sound. The first heart sound is S1, the so-called as lub, caused by the closure of the mitral and tricuspid valves at the onset of ventricular systole. This is very, very important because it's at the beginning of the ventricular systole. The mitral and tricuspid valve closed, and that produces the first heart sound, and it is best heard at the apex of the heart. What are the abnormalities of intensity of the first heart sound? That is quiet. If S1 is quiet, it may be a low cardiac output state, poor LV function, rheumatic mitral regurgitation. Remember MR. Okay, in MS we will get loud S1. Okay, soft or quiet S1 is seen in case of MR, or in case of first degree heart block we will get quiet or soft S1. Loud, of course, increased cardiac output, large stroke volume, short PR interval, mitral stenosis. And variable intensity is appreciated in complete heart block, remember, and atrial fibrillation and extrasystoles are other very rare causes, but remember, in complete heart block, variable first heart sound intensity is observed. Coming into the second heart sound, it is S2, the so-called as DUP, caused by the closure of the pulmonary and aortic valve at the end of ventricular systole. At the beginning S1, at the end it is S2. It is best heard at the left sternal edge. S1 is best heard at the apex. It is louder, it is higher pitched than S1. And remember, the S2 has two components. One is the aortic component, we call it as A2, and the pulmonary component called as P2. And out of this, which is usually louder, it is A2 which is louder. What do you mean by physiological splitting of second heart sound? That is, I told you, the two components. Actually, it is very, very difficult to appreciate that physiological splitting, that is the A2 and P2 components separately while auscultation. Okay, yes, only the experienced ears can pick that. And the physiological splitting occurs because the left ventricular contraction slightly precedes that of the right ventricle. That means the left ventricle contracts first, then only the right ventricle contracts, so that the aortic valve closes first, that is A2, then occurs after that P2 because of the closure of the pulmonary valve. So aortic valve closes first, then occurs the closure of the pulmonary valve. And this splitting increases at the end inspiration because increased venous filling of the right ventricle, and it further delays the pulmonary valve closure. That is why we ask the patients to hold their breath for some time, okay, so that at the end of the inspiration we will be able to appreciate the physiological splitting of the second heart sound, and on expiration it completely disappears. Yes, so lub, dup, okay, yes, so that splitting is heard, appreciated only during inspiration, and in expiration that splitting is vanished. So you can see here the A2 and P2, that is a physiological splitting, and we have another conditions where occurs the so-called as the fixed splitting of the second heart sound and reversed splitting. What do you mean by reversed splitting? That is P2 occurs followed by A2. That is the closure of pulmonary valve occurs first, followed by that the closure of the aortic valve occurs. That is called as reverse splitting. It occurs in case of left ventricular outflow tract obstruction as well as in case of left bundle branch block. Okay, yes. And what do you mean by fixed splitting? Okay, fixed splitting in the sense in every cardiac cycle, okay, the duration between the A2 and P2 component remain fixed. That is called true fixed splitting, and it is actually a characteristic of atrial septal defect. Remember ASD. Reverse splitting occurs in case of left ventricular outflow tract obstruction and left bundle branch block. Remember, fixed splitting is not that much clinically important, but reversed splitting of second heart sound is very, very important. And increased splitting, okay, that is the duration between A2 and P2 is high. That is called increased splitting of second heart sound. It occurs in case of right bundle branch block and pulmonary hypertension. Remember, reversed splitting occurs in case of left bundle branch block. See, there are lots of causes. Okay, there are lots of causes for fixed splitting, reverse splitting, okay, increased splitting and everything. But what is given in Macleod, those examples, that one or two examples that are the most common ones that I strongly advise, that is more than enough. So coming into what are the abnormalities of the second heart sound, as I told you again, in calcific aortic stenosis, and aortic regurgitation. Why calcific aortic stenosis? Because the valves are calcified, so you will get soft S2. Okay, low cardiac output. Whereas in case of systemic hypertension, you will get A2 is more loud and P2 is more loud in case of pulmonary hypertension. And I told you that in pulmonary hypertension, you will also get what? Enhanced splitting. That is, there is an increased gap. That is called as increased wide splitting. Okay, that occurs in case of pulmonary hypertension and right bundle branch block. And fixed splitting, as I told you, what do you mean by what widened splitting means? It widens in inspiration. That is called enhanced physiological splitting. Unaffected by respiration, that is called fixed splitting. As I told you, it occurs in case of atrial septal defect. And widens in expiration. That is what is we call it as reversed splitting. Remember, it occurs in case of left bundle branch block, left ventricular outflow tract obstruction, as I mentioned, hypertrophic cardiomyopathy, aortic stenosis, and ventricular pacing. Okay, so remember, widens in inspiration, that is enhanced physiological splitting. Remember, pulmonary hypertension and right bundle branch block. Fixed splitting, that means it is unaffected by respiration, occurs in case of atrial septal defect. Reversed splitting, that means that widening occurs during expiration rather than inspiration, which occurs in case of aortic stenosis, hypertrophic obstructive cardiomyopathy, left ventricular outflow tract obstruction, and left bundle branch block. Coming into the third heart sound, it is a low pitch sound. It is an airly diastolic sound. Since it is low pitched, it is best heard with the bell of the stethoscope at the apex. It coincides with the rapid ventricular filling. Okay, and it is therefore heard after the second heart sound. Yeah, so what is actually responsible for the third heart sound? It is a rapid ventricular filling. Okay, and it is normal physiological findings in children, in young adults during pregnancy, but the pathological causes, if somebody asks you, it is because of the left ventricular failure. Okay, and mitral regurgitation you can get. So always S3 means the heart is in failure. So this is what we say in clinical practice. Okay, S3 means it is always heart failure, but even in mitral regurgitation you can get. And sometimes this S3 will be accompanied with the increased heart rate, that is tachycardia. We call it as a gallop rhythm. What do you mean by gallop rhythm? In case of what heart failure associated with the tachycardia, the first and second heart zone will be quiet, and only the third heart zone will be dominant, more loud. That is why we call it as a gallop rhythm. Gallop means like a hose. Okay, how the hose hops. Okay, that is called as a gallop rhythm. So S1 and S2 will be quiet. So S3 means, remember, heart failure. It is both physiological as well as pathological. It is because of the rapid ventricular filling, heard at the bell of the stethoscope at the apex of the heart, low pitched airly diastolic sound. And coming to what about the fourth heart sound? It is less common. Okay, it is again soft, low pitched. So again, it is heard best with the bell of the stethoscope at the apex of the heart, and it occurs just before S1. Okay, just before S1, and remember, it is because of the atrial contraction. Atria is contracting against a non-compliant or a stiff ventricle. It is that atrial contraction that is responsible for S4. That is why it occurs just before S1, and it is always pathological. It is most commonly seen in associated with the left ventricular hypertrophy due to hypertension or aortic stenosis. Okay, because atria is contracting against a stiff ventricle. So what are the causes of stiff ventricle? Hypertension, aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, all those causes stiff ventricle. So the atria is contracting against a stiff ventricle, that is responsible for the pathological, always pathological heart sound S4. And remember, whenever there is atrial fibrillation, means what? Atrial fibrillation, what? Atria is not normal. So, in order for the S4 to be heard, atria should be normal. In atrial fibrillation, atria is never normal. That is why S4 is not heard in atrial fibrillation. Coming into the added sound, first one is opening snap, which is commonly heard in the mitral valve. Okay, just opening snap means it is always mitral. Okay, tricuspid we won't say. So, especially mitral stenosis, and it is again a diastolic sound. Okay, just after the S2, it is best heard with the diaphragm. That means it is a high pitched sound at the apex of the heart. Okay, you can see the opening snap just after the S2, and opening snap, it is always of MS, mitral stenosis. It results because of the sudden opening of a stenotic valve. Okay, in the early diastole, because of the already in mitral stenosis, the valve is stenosed. Because of the sudden opening, you will get a snap. Okay, like a tap-like sound. Yes, and what about the ejection clicks? They are high-pitched sounds. Okay, so they are appreciated like opening snap. They are appreciated with the diaphragm of the stethoscope, and they occurs just after the S1. See, after S2 opening snap, after S1 is the ejection click. Okay, early in diastole, early in systole, that is ejection click. Early in diastole is opening snap, and it is occurs most commonly associated with PS and AS, that is pulmonary stenosis and aortic stenosis. The mechanism is again same like the opening snap, that is because of the sudden opening of the aortic and pulmonary valve. what this ejection click is heard. It is a high-pitched sound, best heard with the diaphragm. It occurs early in the systole after the S1. Opening snap occurs early in the diastole after S2. Yeah, it is for opening snap is for the mitral valve, whereas ejection click is for the pulmonary and aortic valve. Since in calcific aortic stenosis, what happens? The cusps are so rigid, they are calcified, so that the opening will not be smooth. Okay, it will be hard, it will be gradual only, it is not spontaneous opening. So that is why ejection click is absent in case of calcific aortic stenosis. Fine. And what do you mean by mid-systolic clicks? Again, they are high-pitched sounds, best heard at the apex with the diaphragm, occurs in case of mitral valve prolapse. It is mid-systolic means it is always mitral valve prolapse. You can see mid-systolic means in the middle of S1 and S2. Yes, that is called as in the middle of systole. Mid-systolic click, it is always MVP, mitral valve prolapse. Okay. And coming into the heart sounds in case of mechanical or prosthetic valves. Unlike the normal valves, in mechanical heart valves, they will make a sound when the close or open. Okay, and the closure sound is normally louder, okay, than the normal valves, and they are high pitched, they are metallic in nature. Okay, even without a stethoscope, we will be able to appreciate the sound. Okay, and a mechanical mitral valve replacement will make a metallic ES1 and a sound like loud opening snap early in the diastole. See, you can see I am replacing the normal mitral valve with a mechanical or a prosthetic mitral valve. In that, what is happening? The S1 intensity will be more metallic. More metallic means more loud, that even without a stethoscope, I will be able to appreciate. And the opening snap will occur early. In normal mitral stenosis, the opening snap occurs now after S2, that duration will be a bit early. Okay, earlier that opening snap occurs in case of mechanical mitral valve. And similarly, in case of mechanical aortic valve, the second heart sound, that is the S2, will be having a more intensity, more louder in intensity compared to a normal valve. And yes, the so-called as the ejection click, it occurs again like how the opening snap occurs in an earlier duration, even the ejection click also occurs in an earlier duration. So remember, mechanical heart valves, intensity will be more. Opening snap or the ejection click, it occurs earlier. Okay, the duration occurs earlier compared to the normal valves. Okay, so these are the additional sounds. So once again, a quick revision. Remember, first heart sound, beginning of ventricular systole, best heard at the apex, S1 lub. Loud S1 mitral stenosis, soft S1 mitral regurgitation, variable S1 complete heart block. Second heart sound, left sternal edge, end of ventricular systole, higher pitched, more louder, especially the aortic component. Physiological splitting occurs because left ventricle contract first, aortic valve closes first, then occurs the contraction of right ventricle leading to the closure of pulmonary valve. Okay, the separation is well appreciated. The physiological splitting is well appreciated. In inspiration, disappears in expiration. True fixed splitting occurs in case of atrial septal defect. Okay, that is that is unaffected by respiration, whereas widens in inspiration or the enhanced physiological splitting occurs in pulmonary hypertension and right bundle branch block. Reversed splitting, widens in expiration occurs in case of aortic stenosis, left ventricular outflow tract obstruction, left bundle branch block. Third heart sound, low pitched, early diastolic sound, best heard with the bell apex, coincide with the rapid ventricular filling. And remember, it is physiological as well as pathological. Pathological means it's always heart failure. Yeah, so called as the gallop rhythm. Fourth heart sound, it is always pathological. It is a low pitched, heard with a bell at the apex. It occurs before S1. Atria is contracting against a stiff ventricle. So what are the causes of stiff ventricle? Aortic stenosis, hypertension, HOCM. So for S4 to be heard, atria should be normal. In atrial fibrillation, atria can never be normal. That is why S4 is absent in atrial fibrillation. Added sound, opening snap, mitral valve, sudden opening of a stenosis valve, early diastole, just after S2, best heard with the diaphragm at the apex of the heart. Ejection click, high pitch sounds, best heard with the diaphragm. Okay, occurs in pulmonary or aortic stenosis early in the systole after S1. In calcific aortic stenosis, ejection clicks does not happen. Mid-systolic clicks, mitral valve prolapse. Okay, and mechanical heart valves, the intensity will be more compared to the normal heart valves, and ejection click and opening snap occurs at an area duration. Hope this video helps for all. Thank you.